All right, so tonight we're going to go over transitioning arthroplasty to the ASC. So I want to thank OrthAlign for putting this on tonight and our speakers. These are my disclosures, one of which is relevant to this with OrthAlign being one of the disclosures. So we look at kind of why are we transitioning to the ASC. As we've seen, the number of arthroplasty cases continue to grow exponentially, as we see potentially by 2030 over 600,000 total hips and over 900,000 total knees. And with these increased numbers, we're really seeing value-driven healthcare as a result. And so as we see this value-driven approach, it's now leading to incentives for decreased costs and then shorter postoperative lengths of stay. And as we've seen in this value-driven environment, same-day discharge has proven a number of things, one of which is there's been no increase in readmission rates as a result of doing these now at same-day surgery centers and ASCs. It's really proven to be cost-effective with potential cost savings to CMS of $300 million in bill charges and even $87 million in reimbursements annually. So as a result, CMS removed total knees from the inpatient-only list back in 2018, and then this year alone allowed it to be done at freestanding ASCs. So we've seen as a result then same thing with total hips. They're removed from the inpatient only list in 2020 and potential then for freestanding ASC in 2021. So as we look at this transition, it seems inevitable that same day discharge after joint arthroplasty will become more of an increasing role in years to come. And to help facilitate this as a same day discharge from ASC, we really need a well-coordinated team-based approach. And that's what we've seen from all of the folks that are be giving talks tonight. It's really a team-based approach that allows for this to be an easy transition to avoid for complications. So one of the questions then becomes is, well, from our experience, how can then facilitate this transition to the ASC? And so tonight we're going to go over a number of different topics to try and make the transition as easy as possible for those that are considering doing this in the post-COVID-19 era. So it really comes down to patient selection for the ASC, which is paramount to having success. Also understanding the economics of arthroplasty and ASC, making sure that this actually is economically feasible for you. And then the question is using technology at the ASC and what you can use to make this a financially proven benefit for both the patient as well as the ASC. And then things that we've learned from our experience with the top 10, what we call watchouts. So it can be a good experience not only for the patient, but also the surgeon and his staff. So we have an excellent faculty tonight to cover all these topics. Matt Heinrich from Texas is going to go over the patient selection portion. Kevin Fricka from the Anderson Orthopedic Clinic is going to go over the economics of transition to the ASC. Clinton Wooten's going to go over the technology that he's been able to utilize by transitioning to the ASC. And Mike Ass from HSS is going to go through these top 10 watchouts so that, again, we can try and provide a great environment for these folks and have a good experience for both the patient as well as the surgeon. So with that, I'll turn it over to Matt. He'll go over the patient selection portion, covering things from insurance to demographics and what patients would be a successful patient to start doing at an ASC.
Right. Okay, guys. Well, I really appreciate the opportunity to be able to share, with you kind of some of my experiences with doing outpatient total joints. And I'm kind of coming at this from two different perspectives. In that there's sort of what I consider true outpatient surgery, which is patient has surgery, goes home the same day. And then another venture that I've done with a company called Move, where we actually have attached care suites, which has allowed us to expand the scope, which definitely impacts your patient selection criteria. So I want to just touch on that a little bit and kind of go through that with you. And so we'll go ahead and click through this here. These are my disclosures. Pertinent disclosures are really, I am a consultant for OrthAlign, and then also an owner in two different surgery centers, one being the Move Center with care suites and the Hyde Park Surgery Center, which is just a traditional ASC. So we kind of talked about this a little bit about increasing demand, for surgeries. This is a kind of a neat graph I came across. Just kind of when you look at just the overall world population growth, this is where this is all coming from. You look at that curve, you can see how over the years how things are just going exponentially, and we're shooting past the 7 billion mark as far as world population. And so as that's happening, that's driving this increased demand for resources, particularly things like joint replacements, which is requiring efficiency and good patient flow. And so that's why I think we're going to see a lot of this spilling over to the outpatient setting. And so, so when we talk about this outpatient setting, we heard, about, this has been able to be done within hospitals. And then just recently this year, total knees were allowed to go through, for Medicare at least, to true freestanding ASCs. Some of the private insurers have allowed this a little bit longer, but my experience has always been that hospitals, trying to do outpatient in hospitals is very cumbersome. It's pretty inefficient. And hospitals are associated with a lot of less healthy patients or sick patients. This slide I actually did before the COVID outbreak, which seems like it's been going on forever. And but even back then, that was kind of my approach. Now we start looking at the statistics associated with this, and this is even out of date. But we have over 6 million cases now, over 180 deaths. These patients, majority of these patients are all going through hospitals, and so we've all felt that in our practices and not being able to do potentially elective surgeries. And so this is yet another reason why, patients aren't necessarily wanting to go there. And I think we're going to see a big, push more to the outpatient side. So I think the pandemic has definitely had a significant impact on patients' perspective of hospitals, even further deterring their desire to go there, regardless of the efficiency. These are patients undergoing relatively healthy musculoskeletal surgeries. And so they want to minimize the risk of exposure. Really no hospital out there is COVID-free at this point, as opposed to ASCs, which currently at this point really are. So this is really kind of the best option for patients is to seek a surgical facility that's not hospital-based, which is where I think we're going to see a lot of patients demanding to try and get access to an ASC for these type of procedures if they're able to. So with a typical ASC, this is, the ones we've all been operating in over the years. And so the challenge is that they kind of cover everything. So, they're not necessarily designed for total joints. They don't necessarily have the equipment that you need. And so from that standpoint, you have to evaluate what you have access to determine if this is going to be something that'll work. I found that the biggest challenge is that, the equipment that might be required, there's limitations on 23-hour capacity because these weren't built for this. But this is kind of a classic model. And we look at the reimbursement for total joints, it definitely warrants evaluation, but there are limitations to scalability based on these 23-hour rooms. There's some limitations sometimes on the sterilization capacity and even the storage capacity. So this is something I think that anybody that's started down this venture is starting to come across. And so because of that, myself and my partner a number of years ago looked into and developed them sort of from the ground up, a center really with a focus on joint replacements on all fronts. And this is the MOVE facility that I talked about that incorporates care suites in addition to the ASC. But we built it for total joints. So we increased the sterilization capacity. There's more pre-post-op bays. We have the attached suites. For the extended stay afterwards for the patients and staff with nurses. We have in-house physical therapy. And in addition to that, we have dedicated nurse patient navigators that help to engage with the patients for education that starts before the surgery, available to them while they're at this during their stay, and then also follow up with the patients afterwards to help us collect data and just keep the entire process running smoother. We really found that this integrated pathway really helps increase the amount of patients we can take care of because it allows for more hand-holding and things of that nature that in the past you would only get in the hospital. So this is just a picture of this MOVE facility that we built. And again, when you build it from the ground up, you can make it exactly the way you want. This is what the care suites look like. So a little different than your typical hospital, and what one of the patient room looks like. So on to patient selection. So, and I kind of ran through those things because, and I'll get into it a little bit more when I get to some of the stuff at the very end here about how we've kind of expanded our indications. We have the care suites attached with the support of a navigator and things of that nature. But typically, particularly before this year, when we started doing total knees in the freestanding ASC, when I thought about doing outpatient total joints, whether it be hip or knee, I pretty much thought when I'm seeing a patient in the office, things that, my first glance for is this patient a potential candidate or not, after identifying a patient with arthritis was, all right, is this patient, under age 65? thinking, right, if they are, then potentially have a private insurance that would allow this. We've heard about Medicare, and so and some of the advantages there now have made that another option for us. But before that, that was definitely a limiting factor. The other big one is really cardiac issues. We really didn't want to see any significant cardiac issues for the patient because there's a limited capacity to watch that, monitor it, or treat anything along those lines. Didn't like to see a history of blood clots, and so we also didn't like to see patients that required ongoing anticoagulation therapy. So these would be patients with AFib, stroke, DVT. We took these screen these patients for urinary retention. Not necessarily that they couldn't have surgery in an ASC setting, but we wanted to be able to treat it to try and minimize those impacts. And obviously, these are patients that need to be motivated, that need to have adequate support at home in order to have success. Now, this is it's funny, when I looked at my criteria, that first page is really my first glance when I'm seeing a patient, thinking about who I want to go. That's what's in my mind. These other ones are almost subconscious for me now at this point, because this is really kind of for any patient having a total joint, this is going to be your criteria. So you don't disregard this criteria. So this also applies. So, BMI needs to be under 40, hemoglobin A1C less than 8, no significant anemia, no major renal disease, no significant pulmonary disease, no liver disease. So, obviously the patient has to meet criteria for a joint replacement, just like they would anywhere else. That doesn't really change. As far as when it comes to patient selection in the ASC, like we talked about, motivated patient and home support are critical. The patient's really kind of losing out on that opportunity that they used to have in the hospital of having a couple of days to get comfortable with going home. And then a lot of times having that option to be able to go to something like a skilled nursing facility or rehab. And so that's something very important to look at. It's also very important that since you're losing out on that opportunity for the education while they're in the hospital, in preparation, that has to be done, all preoperatively. You got to front load it for the patient who's going to be going home the same day. Now, if you with the facility where we have the stay suites attached, we do get that opportunity to also have the supplemental time while they're in the suites to also prepare them for that transition to home, which I think does help a lot from that standpoint. As far as cardiac issues, I'm really here, pretty much these have to be, pretty squared away patients. No pacemakers, no arrhythmias, no recent cardiac stents. If they've had a CABG in the past, that's okay, but they have to be fully recovered and off all anticoagulation. And of course, any of these things, any issues, the patients have to have formal cardiac clearance. For history of DVT, really this is the patient that had a legitimate DVT, required extended treatment, and has essentially been, if they had a true issue that led to that, then these are patients you're not going to want to necessarily do in the outpatient setting, just because of the risk of hematomas and things of that nature. Now, if this is more of that remote history where they tell you that, 20, 30 years ago while on birth control, they got a blood clot, superficial clot, and it went away with just aspirin or something to that effect, that's really not what we're talking about. But that's something you definitely want to be focused on. For urinary retention here, really just want to make sure you have this discussion with your patient pre-op. You never want to be sitting there the day of surgery and you're doing an outpatient case, particularly a true outpatient case, and the patient's having difficulty urinating, and you're then asking them, well, have you ever had issues like this before? And they say, well, actually, now that you say that, the last time, I had surgery for whatever, my rotator cuff or something along those lines, I had to have a catheter and it took like a week before I could pee again. You want to find this stuff out beforehand, because this can really make things challenging when you're trying to treat these patients in an outpatient setting. And so the other thing I often will ask is just if the patient has a history of frequent urination at night. For men in particular, this is kind of a hint that they probably have some mild BPH, and some of these patients will go ahead and treat prophylactically, for like a day or two pre-op, and then for a couple of days post-op to avoid the need for catheterization. And I've had pretty good success with that. And if they have a history of known retention, then a lot of times we'll ask them just to see the urologist preoperatively to have a game plan, maybe modify their medications going into the surgery. So we talked a little bit about Medicare and CMS and what they're doing. So obviously they've allowed outpatient total knees in 2020. They also are now going to be allowing outpatient total hips and freestanding ASCs in 2021. The even better news, I think, is that they're actually increasing the reimbursement for facilities by 2.3%, which at first, glance doesn't sound like a great deal. And it's not a great deal, but it's an okay deal, because the amount of reimbursement that we get, per case, for Medicare cases is a razor thin margin. And this 2.3% really helps make up a significant difference in profitability. And so what it does is it now is going to take the entire Medicare population and make them fair game financially, as long as you're doing this in conjunction with a mix of some private insured contracts for your patients. As far as the insurance is concerned, really private insurance contracts are very facility specific. So you just need to see what they are. There's a lot of variability as far as whether they cover the implants, if they cover any technologies that you're using. And so you want to know those kind of things before you're just selecting these cases. You just want to know what you're dealing with at your particular center. So make sure you check into that before you just start signing up patients regardless of insurance. As far as the patient experience, we want to mobilize them as soon as we can after surgery. We typically do that with PT or nurses if we're in our true outpatient center. Like them to be able to get up, ambulate, be able to use the restroom before they leave. Typically, patients are able to be discharged from the ASC either to home or to the suites within 2 to 3 hours. And we typically set our patients up with an online PT protocol that could be done independently from home, or possibly home health if we feel like they need a little more help. And then the follow-up is simply our standard coming back in at 2 weeks and 6 weeks for their typical post-op checks in the office. And so this is looking at some of the program characteristics from our MOVE facility. And I mainly put this up just to show, like, we're not just cherry picking, and actually I'm not going to bore you guys with a ton of data. We have a slide in another data thing showing that essentially about 20% of our patients are actually ASA 3s that we run through our program. So we're taking on patients with some comorbidities and things of that nature, and our outcomes are excellent. So from that standpoint, it really kind of shows that as we start to embrace the outpatient concept, you'll be surprised what patients are actually adequate candidates for this type of approach. And we track all the data on these patients, which is another nice thing. So you can see, good tracking with HOOS and HOOS Junior scores. And so, so in summary, I think ASCs that are designed for total joints are going to play a really large role in this expanding need for total joints over the next 20 to 30 years. Efficiency of patient flow is going to be critical to this process. If you can't do this thing, efficiently and well with good outcomes, then you won't have success. And obviously, we're going to see patients will seek this option out over traditional based approaches, and there's a lot of reasons behind that. And so. So with that, I'll end, and I've got my email up here and phone number. If anybody has questions or wants to reach out, feel free to. Always love to try and help out colleagues.
So Matt, that was great. A couple of things. Do you work with a hospitalist to review cases to kind of earmark those that are going to be transitioned to the ASC versus keeping them as an inpatient or same day discharge from the regular hospital?
Yeah, so the nurse navigators play a pretty big role for our more complex cases, and we do have a hospitalist group that we work with that can do our pre-ops and things of that nature, and even help with optimization if needed. So it's, and the other aspect of it is we also get anesthesia involved. I really found that that becomes much more critical than typically, in the hospital-based setting. It seems like, you kind of throw anything at the anesthesiologist and they're just going to say, okay. But when you really bring them in as a partner, when you have something that's kind of on the fence, you go to them and say, well, and then and feedback for optimal anesthetic to use for the case, whether it be a spinal, a regional block, or true general, that really plays a big role. But definitely medicine plays into this in a big way.
I think that's the key part that you hit on, is really making sure everybody who has a stake in the game gets involved, because then really everybody's on the same page, and all it takes is one person to really give the wrong message to make the ASC transition. I shouldn't say a failure, but it makes it a lot challenging if someone gives the wrong message, is not really on the same page with everything.
No, absolutely.
Yeah, I would agree with that as well. Our anesthesiologists review all of our cases there as well. So I think that's important. And I think Matt touched on a good point. What is the biggest hurdle to discharge is urinary retention. So as we get into this outpatient world, screening for urinary retention is important. We treat a lot of patients with Flomax ahead of time, even if they have any kind of history of urinary retention. So I think Matt brought up a good point. I mean, patient selection, but then we're talking about hurdles for discharge. Mike might get onto it later, but urinary retention is probably one of the biggest things that may disrupt some of the efficiencies in patient flow at an ASC.
If I can, question on that, Kevin, are any of you guys in the surgery center transitioning on a patient other than just maybe using a Flomax ahead of time to doing a short-acting general to avoid that? Obviously with the spinal, sometimes that urinary retention is a bit larger. So our anesthesia team has started to look at that on some of those folks that have that history for that same reason.
Yeah, I would agree with that. I mean, we're a regional heavy place, but I think there is some role for the ASC in general anesthetic. We try to make our anesthesiologists run the patients not too wet. Higher fluid volumes also can lead to urinary retention. But you're right, for someone who has a significant history and is able to tolerate general, that may be a way to go and something we should look at.
Yeah, and also keen on that as well. At our center, it's interesting because we're tracking data on every patient. So, and I've kind of taken the stance of the general anesthetic side. So my patients essentially get a general anesthesia because it allows them to ambulate quicker after surgery, whether it be a knee or hip. And so when we're following it, we have, and then my other partner does predominantly spinals, unless the anesthesia has a preference or the patient has a preference. And what's interesting is we really haven't seen a difference yet in our numbers. We're about close to 1,000 cases in at this point. And but that's one of the reasons why I'm tracking it, is to see if we can start to get some something that's publishable to show some guidance on that, because it definitely makes you think about it differently.
And on that note, I mean, we do lidocaine spinals, which a lot of anesthesiologists are not comfortable with because of some paper with some transient neurological symptoms in the past, or transient neurologic radiculitis. So we're looking at putting together our data on lidocaine spinals because at least that has a little less urinary retention as well. In these uni cases, or straightforward total knees or straightforward total hips, a lidocaine spinal is adequate enough and gets them moving quicker. So, interesting things we do need to take about. We do need to. Anesthesia is the big part in the ASC in getting people home, so it is something we should continue to talk about as well. If you want, we can transition to my talk. Is that where we want to go, Steve?
Yep, I think it's a perfect parlay to understanding the economics of not having urinary retention at your hospital. So,
yes. Thank you. My name is Kevin Fricka. I'm from the Anderson Orthopedic Clinic. I'm part of the fellowship there, and I'm going to talk about the economics. The economics I'm going to talk about are a little bit both from the surgeon perspective as to, as a surgeon wanting to take part in an ASC, and then also from the side of, what is the reimbursements like in terms of each, type of joint replacement, and what technology you can use at the ASC. So again, my disclosures, relevant is going to be, I'm a consultant for OrthAlign, but I'm also a surgeon owner in our surgery center, which is called Harborside Surgery Center. I did my fellowship at Rush, where we were doing outpatient surgery back then, but moving over to Anderson, we didn't necessarily embrace outpatient surgery for a while. But in 2013, essentially, we started a joint venture with one of the ASC groups. And the nice thing there was they gave us a heads up on when they were building it. And so I was able to actually really practice in the hospital outpatient surgery for about a year before our center was built. And then, once our center was open, the surgeons, could hit the ground running. And so now, this is 2019, but, we do about 2,500 cases there. 90% are ortho, and about 400 to 500 joint replacements a year, to include knees, hips, and partial knee replacements. We talked about this, the economics. I mean, there is going to be a huge increase in outpatient total joint surgery. And I think actually the COVID crisis or pandemic is actually making that transition in talking with the patients a little simpler, because as Matt pointed out, patients do nowadays kind of associate the hospital with sick patients, and a lot of patients are looking to have surgery in another venue. So there is a huge shift from volume to value, and the financial responsibility is now on the provider rather than the payer. A lot of the bundles, the issue as well, and I think Matt touched on having therapy done, remotely or digitally is another way to cut down on the after costs after joint replacement. But as we've talked about, Medicare is essentially taking total knee and total hip off of the inpatient list, and they're transitioning them to the ASC. I wouldn't say you want to fill your ASC with Medicare patients, but it is a way to get them there, and in supplementing it with private insurance, I think you can do it. Again, this is just saying that, hey, joint replacement is moving to, an outpatient procedure for most healthy patients. And I think as a surgeon who wants to be capturing that volume, you need to be able to plan on transitioning to an ASC. So an ASC typically is less than 24 hours of care, so it's a truly outpatient surgery. And this is the Academy position statement. They're behind it. Many orthopedic procedures can be performed safely there. It can improve patient access to a high quality care model. And in some cases, it's actually a lower cost barrier for the patient. As a surgeon who may have a stake in it, they do want you to disclose your interests. So when you look at an ASC in terms of financial feasibility, there's a lot of ASCs going up. And in the past, the joint replacement surgeon did not really have a role in the surgery center, but now you become one of the more valuable pieces to the surgery center because your cases are high reimbursement cases. So in order to have an ASC that's financially feasible, you need to understand the revenue is the number of cases and then the expected case reimbursement. And the high reimbursement cases now are hip, knee, and shoulder arthroplasty, spine, as well as hip arthroscopy. And in order for it to be profitable, there needs to be a commitment to a number of cases. So having a surgeon who's part of an ASC who does one case there a month is not going to be a financially feasible partner. You want someone who's going to plan on, booking or scheduling the ASC first. So, if you're a high reimbursement case center, you might be able to be financially feasible with about 2,000 cases. But if you've got a lot of hand in sports and only one joint surgeon, you're going to need a lot of cases in order to make it feasible. And so you need to talk to the surgeons. Who are you looking at joining the surgery center with? Looking at their volume. What outpatient cases can they bring? What is their case mix? Is it high reimbursement cases or low reimbursement cases? And how do they schedule? Some people are set in a routine and Monday and Wednesday are their cases, and that's when they're going to do surgery. But an ASC, to be financially feasible, you have to be somewhat flexible. And they may give you times at different times. You got to be willing to change your schedule around potentially to take these cases there. And then again, what's your rate of Medicare versus private? I mean, it can't be a Medicare-only surgery center. It just won't be feasible. There needs to be some private insurance there as well. And so you need the surgeon to commit. It's the first place that I schedule. I know my days there. It's the first, third Thursday, third and fourth and fifth Friday. And my surgery scheduler knows that's the first place that I'm going to be scheduling, patients. As far as a surgeon, you have to understand, are you comfortable and capable of doing outpatient surgery? I think you need to, know your practice, know your efficiency. 2-3 hour knee replacements are not going to be done well there. You need to understand your complications and look at the past, what you've encountered, and what your length of stay is. I mean, if your current length of stay at the hospital is 3 or 4 days, you're not going to be able to transition right to the surgery center. You need to start working on getting that hospital length of stay lower and then work your way to the surgery center. As we talked, Matt said, screen and optimize your patients. Again, you can practice at the hospital. It's a little bit cumbersome, but if you work there early, there at least you have a safety net if they needed to stay. And then you can, figure out, okay, well, these patients were a little higher risk. That's why they stayed. These healthier patients went home. And so I can transition that to the ASC. It is very important that they have someone at home with them. And so part of the interview when you're scheduling the patient has to be, what do you have at home? and then have a role in the ASC setup so you can focus on how the joint replacement rooms are going to be. You know, some of the older surgery centers may not have the rooms or the sterilization capacity for, you know, these more complex cases. Now, you also need to know your market and payer mix. If you're a heavy Medicare place, if 70% of your cases are Medicare, you just have to understand that going into the surgery center. Initially, when surgery centers came out, there was this out-of-network model, which actually was a very good reimbursement model for the surgeon and for the facility. But that model is not a model to stay, because a lot of insurance companies are, you know, taking away that benefit from the patient, and the patient is now having to pay more to go out of network. So essentially, most surgery centers, as they mature, are going in network, and that'll be the more viable insurance plan, you know, for the surgery centers in the future. Some surgeons will do a joint venture with the hospital, and that's still a good way to do it. You know, you just may not get as much financial reimbursement for the surgeon themselves, but it's a good way to partner with your hospital, if that's what you have, to get them out of the hospital and get them into a surgery center where the efficiency is better and the physical therapy and the flow through is better. You can do outpatient surgery in a hospital, but the flow through is just not as good. And so if we look at Medicare heavy, you know, they're only going to pay about 65% of what they pay to the hospital in an outpatient setting. The surgeons themselves next year are going to take a 5 or 10% cut from Medicare. So you just have to understand, you need to not have a Medicare heavy surgery center. It can be intermixed with private payers, but we have to watch in the future whether or not the commercial insurance is going to adopt Medicare reimbursement. You know, value is now the buzzword in healthcare, and it's quality over cost. And outpatient joint replacement has the potential for maximizing value by improving the quality as gauged by patient satisfaction, and at the same time decreasing costs. This is the first time that if you're part of the ASC and the surgeon now have a cooperative effort to respect the purchase of materials and services they provide to reduce costs and improve clinical benefits. At the hospital, you sometimes may have that with gain sharing, but if you open up another batch of cement at the hospital, or you waste an implant at the hospital, you yourself don't get affected by that. But when you take an ownership in the ASC, those become a big part to maintaining the economics of the ASC. And so a decrease in cost cannot result in a decrease in outcomes. If that happens, you're not going to get the patients coming to you. Word of mouth, you get bad outcomes at an outpatient surgery center. You don't want to do that. Good is if you increase the cost and increase outcomes. So if there's an incremental increase in cost and you get better outcomes, that's good. But better would be to decrease the cost and not affect the outcomes. And the best would be to decrease cost and improve outcomes. And that's what the surgery center is trying to do. Decreasing the cost and improving the outcomes with better patient satisfaction, and you know, earlier discharge, and you know, getting patients a well done joint replacement in a healthy facility, unlike a hospital. So the expense management, though, becomes important. And this is what I'm talking about. A lot of your expense is done on staff. And so as a surgeon who owns a surgery center, or as part of that, you're just going to have to watch your hours. You're going to have to cross-train a lot of employees so that when one is out, the other can do the job. Another big part of cost is the supply. And you as a surgeon are going to have some say in controlling that cost. And then there's facility and maintenance fees. That's really kind of a fixed cost, and you're not going to have too much in terms of being able to manipulate that. But the implant manufacturer for you now becomes someone who you don't want to necessarily take an adversarial role with them, but you've got to talk to them and say, look, we're moving to the surgery center. We've got to keep our costs down. And one way would be to establish a ceiling. You know, you have several implants you may want to use, and you can say, it can't be higher than this. Most of the companies nowadays will meet these, you know, costs, because we should not be paying a premium for implants now that have been around for a long time. There's not the new sexy implant or something that needs to cost more. Gain sharing, if you can control the cost, and you'll share in the profit. You know, bundle payments is a way to go, and bundling the implant in there and the aftercare can help. Again, minimize instrumentation. You know, your surgery center is not going to be a place where you're going to have, 17 trays. You just won't be able to get the throughput through that you want. So you have to minimize that and explore different rep models. A repless system, potentially is a more cost-effective way to do this. And then new technology must provide value. So new technology at the ASC can't be the $1 million robot, but OrthAlign has an ability to provide you with surgical navigation and give the surgeon confidence to perform total joint replacement in an ASC. It has hip, knee, and partial knee applications. So this is a way that you can potentially improve value with a little increment in cost and improve outcomes. The challenges at the ASC, and we'll talk about this on a lot of the others, but the doubters, you don't want anyone along the process to talk to the patient and doubt that they can come home. You also don't want the surgeon who's just, hey, I'm going to do what I want at the ASC, spend the money, have no, concept of cost, okay? And you don't want the surgeon to say, well, they've got this over there, so I need a robot over here. I can't do it without a robot or things like that. You have to understand these risks to make these centers financially feasible. Anesthesia we talked about. We have control over our anesthesia, meaning that we signed a contract with our anesthesia group that says if there's an anesthesiologist who comes to the surgery center that doesn't perform up to our standards, we can say we don't want that anesthesiologist there, because that's a huge part in terms of getting these patients through. We talked about the out-of-network thing that's probably not going to be there. So if you're in an out-of-network center, you're going to have to look at ways to get in network. Adding and subtracting owners as an owner can be difficult at times, but you don't want the surgeon who does one case a month. You want someone who's dedicated to the surgery center. They can fail, so don't overspend on real estate. Don't overbuild, meaning you need to know how many cases you're going to do. A 6-room surgery center that's empty is not going to be profitable, where if you do a 2-room surgery center that's filled to capacity, that's going to do very well for you. You need strong leaders or strong surgeons who are interested in this and committed surgeons with the right case mix. Do not overstaff, and just understand that technology has a role in the surgery center, but it can't be something where the cost is prohibitive. This is something that you're taking part in and you own now, and that's how the economics pan out. So the surgery center provides both the patient and the surgeon satisfaction. Success depends on our involvement and commitment, and orthopedics can drive this. Our ASC is essentially a focused factory. 90% of it is orthopedics. Simplicity and repetition, breed competence. I primarily do knees there, and my other partner primarily does hips there. Our staff is trained on that, and it's a repetitive process. We can do it in an efficient way with safety as our #1 priority. So again, choose the right patients in the right cases. If you're trying to start this, I think the partial knee is the easy button to start. And then if you need some technology to give you confidence in doing that, I think OrthAlign has the ability to be a confidence booster for the surgeon in the ASC to be able to accomplish surgery safely and efficiently. So thank you for that. I just wanted to give an overview of sort of the economics of joint replacement and in the outpatient center.
So Kevin, that was great. It seems like the biggest part probably is having control over everything. Probably for a lot of us, we've taken economics classes online during COVID-19 because, we ran out of Netflix classes to watch or whatnot. What was the biggest thing that you were able to do to understand the economics as you transitioned years ago from the ASC to make it financially responsible? Did you work with, a financial advisor or somebody to kind of help you make this financially worthwhile for you to do?
We had a good management team with us in terms of the company that we used, which was Surge Center. But I think one way that surgeons can gain this is, and again, either surgeon visitation through Zoom or VSP, visiting a surgery center in your area that does outpatient joint replacement, will give you that. Our center is completely transparent in what we will get per case. So, not as far as a surgeon, but what the facility will get. So if you have a question, I've got this patient and I want to do a total joint replacement at the center, and you have questions about how feasible it's going to be, we can, send that case to our manager, and she'll come back and say, okay, this is where you're at in terms of reimbursement. But I also think being an efficient surgeon, and then, taking some ownership in implants, supplies, do you need the latest and greatest dressing? Do you need, 4 batches of cement for a total knee? Things like that. Just understanding that as a surgeon who has a stake in it, now you can, control your costs.
And is this something that you review on a quarterly basis then with your partners as to what the overall costs are, so that you can kind of see what the in and out is, or how are you continuing to evaluate in kind of the current era then?
Yeah, we do have a quarterly meeting, and new technology is reviewed there. So if a surgeon wants to buy something, he's got to present it in front of the partners, and we have to feel that that's going to be financially feasible. We don't have a robot. We do surgical navigation there, or smart navigation with OrthAlign, but we don't do the robot. We have a HANA table for our anterior hip surgeon. And so there are certain things, if you're starting out and you're an anterior hip guy, and, you don't need the table and you can do it off the table, that's a good way to, if you can do both, that's a good way to do that at the surgery center and then at the minimize cost. But just understanding that, there is no free lunch. You're now the boss and you're part owner there. So you just have to review your costs and understand, we know what insurances are going to do well. So, it's not that we're cherry picking, but, when I schedule my cases there, I can't do a full day of Medicare. It's got to be a couple Medicare and a couple private payers as well.
All right, well, we'll transition to Clint. Clint's going to go over the technology portions of trying to incorporate this into an ASC from operative time and logistics with OR space, and then SPD with turnover. So, Clint, I'll turn it over to you to go over this.
Thank you. Kevin hit on a couple of great points. Let's see. There we go. So technology in the ASC, and I think we already have touched on a lot of things that are really important relative to how to make an ASC successful. First and foremost, patient selection. Second of all, understanding the economics. I think one of the things about a surgery center is it takes a physician and you have to then become a businessman. And for a lot of us, that's something we enjoy. For others, it might not be. And so I think you need to understand those roles. And like Kevin said, get good leadership in place. And then when we look at technology, those good leaders, I think, can make good decisions, because there is some capital cost that comes with some of what we do. And we're trying to find that happy balance of trying to provide the optimal joint replacement in 2020 and beyond, but be able to do it in a fiscally responsible way. So by way of disclosure, similar to the other folks here, those are my disclosures. Relevant is OrthAlign. I am a physician owner in 2 groups. One of them is similar to Kevin, with a partnership with Search Center Development. And I think my background is a little bit unique and helpful in just trying to understand how I got from point A to point B. So those learning curves that we've all talked about. So I trained at Mayo Clinic. At that time, there was no technology there. It was a somewhat technology adverse, if you will. I did a fellowship at Ortho Carolina, again, just finished in 2015. And at that time, nobody there was utilizing technology. So I came out of that training as a true gap balancer on the knee side, whether it was a partial knee or a total knee. And then I was, radiographic driven direct anterior approach surgeon. And I felt like I had a pretty good handle on optimizing a total knee, appropriately balancing the gaps, feeling like my knees felt good. And I felt like on the hip side, I was radiographically able to replicate things in a way that was pleasing to me. I came into a 2-hospital system. Utah is unique in that we're kind of driven by insurance where people can go, a little bit more than maybe some of the places I trained. And one of those facilities had Mako, secondary to a partner of mine, and one of them was without. And so in those first 2 years of practice, as I evolved and started to use Mako and robotics, I noticed some of the advantages, some of the information that I felt that I was getting, that I felt like anecdotally I was seeing better results in patients. And so I started to look and ask the question of what other opportunities and options out there, knowing that in my other hospital, I didn't foresee robotics transitioning there anytime soon. And then in 2016 and 17, I had the opportunity to participate in 2 of these surgery centers that were physician owned. And so similar there, I knew there was going to be a capital call, I wanted to be able to make the right decision for patient, provide them with the surgery that I still felt was optimal, and not feel like it was driven by me making a financial decision, bringing them to a surgery center. And so the predicament that I found was I was asking myself, how do I create similar results without the same capital costs in a surgery center? So the 3 core questions, I think, when we're evaluating any of these technologies, and as Kevin alluded to, when you're looking at your management group and who's making these decisions, number 1, is the new technology fiscally positive? Is there an opportunity that there's a price incentive or a financial incentive that drives that? Number 2, does the technology fit or expand our case mix and case scheduling? We similarly, and it sounds like both of my colleagues that have spoken, have a primarily orthopedic-driven surgery center. And in doing that, we have to ask ourselves, is the technology that we're bringing in going to add to that case mix? Is it going to add or prohibit some of our case scheduling? Are we going to be hindered by having to move a robot in and out or space? But really, looking at what that might do to our scheduling conflicts in the case mix. And then just realistically, is it going to drive volume to justify the expense? I think when we come into surgery centers, sometimes we may want to bring other surgeons if they have the ability to drive more volume to that. There might be other times that we wouldn't want to drive certain surgeons based on some of the characteristics that were already described. But then we want to ask ourselves, is the technology that we're utilizing, or is that outcome that's going to be driven by adding some technology, going to be beneficial? So then the next question is, when we look at technology, why, right? When we look at total joint replacement, and I think more so on the knee side than on the hip side, but the question is why? And I think the answer is we have cases that look good or x-rays that look good and feels bad. And we have numerous studies. There's a collective group by Bourne from CORE with over 1,800 patients. And when you look at patient satisfaction, we know that target on total knees right now, depending on the study you look at, is anywhere from 75 to 85%. And that's pretty consistent across the board. And when they looked at this and they looked at computer technology or some kind of aid, whether that's handheld, whether that's robotic, and we look at questions primarily 2 and 5, where pain at rest and recreational activities, and we look at some of the patient satisfaction, there's an increase. And we're seeing more and more studies with this. This technology is not going to disappear. If anything, we're just getting to the early side of what we're seeing with technology and how it's changing orthopedics. And we're going to start seeing more and more studies released that are independent, maybe less biased than what we previously have seen, that support technology and show that we are hitting the target a little bit more closely. So why do they look good and feel bad? Well, if we look at the primary reasons, it's probably instability, pain, contractures, potential alignment issues. I ask myself, are we having the same problems that I might have at times? We have an x-ray that we thought maybe intraoperatively on the hip side looked perfect. They come back to clinic and it doesn't look exactly like we anticipated it looking at that time. We might have a knee that we felt like was well balanced that just isn't perfectly balanced in the end. We have those patients that come in with unexplained postoperative pain. They're dissatisfied and we don't have a real reason to answer that question for them. On the hip side, we might have some subtle limb length discrepancies. It's interesting to me when we look back at the old data of what was accepted on a limb length discrepancy relative to what's accepted today. There are plenty of studies in the late 80s, early 90s, and even late 90s that talk about 1.5 centimeters. And I think in today's world, you leave somebody 1.5 centimeters, you're in trouble. And that's going to not end in favor or favorably for you, excuse me. When we look at what we're doing with the joint, are we changing their center of rotation? Do we have a less than perfect cup position? And is there simple technology that can allow us to do that reproducibly in a surgery center? The last thing any of us would want, that I think Kevin touched on well, is a bad outcome coming from a surgery center in a small community or even a large community can really be the beginning of a downward spiral for a surgery center. And so if I can optimize that with technology without adding a big cost, that's something that I'm looking for. Have I, objectively increased their offset, decreased their offset on a hip, and what does that do with the subsequent sequelae that come? So we've all been taught, and we know the tenets of a successful total joint. We want it to be well fixed, well aligned, and well balanced. But I think what we're questioning today is, what does well aligned mean? Does that mean that we want to cut that tibia at 90 degrees and then we want a neutral mechanical axis? I think that begs to be questioned at this point. And if we don't, again, how do we reproduce something variable from that with manual instrumentation? When we talk about balancing a knee, what does that mean? We can get into a long philosophical debate on gap balancing, measured resection, and that's not the goal. The goal that I have today is to kind of help us understand that technology helps. I think that's proven out. And then what technology can we utilize in a surgery center? With technology, hopefully we can manipulate the implants in different ways. We likely have much less soft tissue releases, which have all shown and proven out early to have better functional results, less utilization of opioids, which we're persistently being questioned about in today's culture. So what is our target? Can we treat the valgus knee and a varus knee in the same fashion? What's your patient's soft tissue signature, right? That valgus knee that comes in at 15 degrees is going to behave far differently than what a 10-degree contracted varus knee might with a flexion contracture. And as we change those targets, how do we do so accurately? And then the next question is, how do we get the new target in the ASC or even hospitals that don't allow for some of these larger devices, larger instrumentations, robotics that do require a large capital call when we're coming into a healthcare crisis financially? We all know each of these, we're familiar with them, they're being presented to us. And I do think on a favorable note, they're providing data that says we need to be a little bit better on the way we go about things, but you're going to spend a lot of this. And I think as the two gentlemen before mentioned, as you move into the surgery center, you become financially invested. You make a capital investment, and now you're looking at it as what can be the potential return. How do I provide as well done surgery as I can, but also maintain a return that's favorable? So I think we're going to continue to see a lot of emerging technologies, artificial intelligence, machine learning. We just saw 3 robots that are being promoted currently. And then we can talk about some of the more feasible handheld devices. In a surgery center, in an ASC, a lot of our rooms aren't the same size. If we go back and look at the size of some of these devices, they're going to take up a big component of our OR. One of the questions I'd like to maybe ask as I get done and move on to the next topic is, in an ASC, how many guys are still running 2 rooms? And if we're running 2 rooms, what's the feasibility of moving devices like this in an ASC from one room to the next? It's not very well. It's not very good. And we certainly increase risk of contamination in a surgery center. What does that mean with processing and turnover time? So these are all questions that you really have to ask in an ASC. So going back to emerging technologies, 3D printing. So again, as we look at technology in the ASC, we want to ask ourselves how we can decrease costs and improve outcomes, and that was mentioned previously. And when we look at technology, my hopes with technology is that we can increase accuracy, and as we do that, that's going to play a larger role in our success of surgery. I think most times, even with manual instrumentation, we do a pretty good job, but I just don't know if pretty good job all the time is giving us as much as we need. We can, with some of our technology, predict our soft tissue balancing, even maybe before the cuts are made. So we've got that long-standing x-ray. A patient comes in, they're at 7 or 8 degrees of varus. Are you going to correct them back to neutral? With manual instrumentation, we can cut that tibia at 90 degrees. But what if we are starting to make the clinical decision that we may want to leave them in 2.5 or 3 degrees of varus, because we know that that might be a constitutional varus that is more favorable for them? Personally, I've seen that, and that's the direction I'm going. And as I look at a device like OrthAlign, that allows me to do it very predictably in a surgery setting without really increasing much of what I need in an ASC. It also provides less variability in our cuts, and I think we can get some bone preservation with technology. So now we want to look at value applications. How can we provide the benefits that we have seen start to bear out in the literature via technology without a huge capital cost? There's certain things that are out there. There's orthosensor that can help if we're looking at tensioning and balancing and what that might mean. But really, if we're looking at something that can provide us with each of the applications, hip, knee, and partial knee, I think OrthAlign fits that bill as well as anything that we have. When we look at that cup position, I don't know what my colleagues are doing, but in a surgery center, oftentimes for us, it's a nurse that's running my C-arm. That's less than reliable. It might even be sometimes a different nurse. And so now I'm coaching them. I'm distracted from my case. What's really nice now is for me to do that with OrthAlign, set my position, know that I'm plus or minus 2 degrees, and then it's a single shot. I have them come in, or I don't have them come in at all. But I've limited the number of x-rays that are required simply because I now have data-driven information and feedback that takes away from the stress of me having to coach somebody different each time on radiographs. I can also get that limb length, and I can also actually get some of that offset information. Same thing as I mentioned when I look at what we're doing on our knees, whether it's a partial knee, whether it's total knee, being able to reproducibly understand what my posterior slope is and make those varus valgus changes. A lot of times if I'm doing that in a manual knee and I cut it at 90 degrees and I feel they're a little bit tight medially, boy, it would have been nice to cut that at 1 or 1.5 degrees and been able to predictably do that instead of potentially maybe making that as a freehand cut or trying to adjust in what my opinion is an archaic device when you look at an extramedullary tibial guide. So these things have been touched on. I think with OrthAlign, the advantage that we're seeing is, number one, you're in an ASC, your upfront cost is really zero. You can sit down and work with your leadership, and as you start to utilize a technology like this, there can be some pricing advantages so that you, again, save even a bit more. But for me, this allows me to give a patient the very things that I would want to give them. It allows me to reproducibly establish the kinematics of the knee in a way that I think are important and in a way that I think sometimes we might otherwise be missing. I don't ever want to feel like by taking a patient to a surgery center, I'm giving them a secondary outcome that would be less well than what I might provide them otherwise. I like that we have all three applications, total knee, partial knee, and our hip applications. I think this does give us a bit of a competitive edge. I agree with Kevin. We don't need to chase everything else that is out there, but it's easy for me. We have folks now that are coming and they'll come to see me and ask about robotics, and it might be an insurance driven for a variety of reasons. But in the end, I'm able to tell them, look, we have technology today that's giving me the exact same information in a handheld device that allows me to still do everything that I would want to do. And I can reliably tell them, which I think is the question I often ask, is what would I do for my mom or my dad? And the answer is I'd be happy to do their joint in either scenario. And now I get the advantages of being at the ASC. And what do we know those are? We're going to have some financial advantages. We have a lower rate of infection. We have a more comfortable stay. Boy, I look at the suites that some of those patients were staying at, and if I come visit Texas, I'm just going to hit you up for a room there. And the nice part about OrthAlign is we're time neutral. And if anything, I think on the hip side, I do a lot of hip still in the outpatient setting. And on the hip side, if anything, I think I'm saving time. And I'm saving time because it's if I get a shot, it's a single shot, and I'm not as anxious about where that picture's at and getting that perfect AP pelvis. And I think as we continue with this, and as we look at kind of some of the discussion before, more and more joints are going to go to an outpatient setting. We're going to have more data that validates what we're doing. We're going to have data that shows technology is improving our outcome. And I think as owners in ASC, what we really need to look at is what technologies can we feasibly do, reproducibly there, that don't have a huge capital expense. They don't take a lot of room in our OR. They don't cause major issues from a sterilization, all of which can really start to eat into your bottom line and slow down your efficiencies. And so on that note, I think this has been a great tool for me, and it's helped solve some of the issues that I had early on. In summary, really what I just said, with healthcare costs and recent changes, we know total joints in the ASC, they're here to stay. That's not going to go anywhere. And I think COVID has played a role in that. I'm sure my colleagues have felt similar, even in the hospitals. As we went back, they only allowed us to take patients that they knew would be discharged home the same day. So they functionally did behave a lot like an ASC. And I saw the inefficiencies in that model. And now as we've gone a little bit further, we do have the ability to spend a night, but it's in a very guarded fashion. They can't have a guest or anybody in there. And so I think that transition has helped a lot of us recognize that there are more patients that can go to the ASC. And so that's been a driving force. I think technologies in total joints is proving to show improved outcomes. And I think that's now data driven, whereas previously we didn't have that information. So I don't think that's going anywhere. And I think the ASC patient is different. I think if we look at a lot of the folks that we're taking care of, they're good enough just isn't good enough. And I think that's a tenet in general with total joints. If I go back to even my training, which wasn't that long ago, there were often times where I would see patients in clinic with one of my staff and I would hear the line, "It's good enough." And I don't think patients today are accepting of that. I think we can be better, and I think we need to be better. And I think handheld devices such as OrthAlign offer us great value, as Kevin alluded to achieve this goal in the ASC. So obviously similar, feel free to contact me with any questions. And I think this is a fun time for us as orthopedists to be transitioning.
That was great. I think you hit on a lot of key points. Predominantly, any technology that you introduce really needs to keep you time neutral. I think a lot of us have done robotics, and no matter how fast we get to do robotics, for me, there's not a Untitled or OrthAlign case that I can't do faster than any robotic case and still achieve what I consider to be the same outcome. And I agree, same thing. If you're a DA surgeon, there's nothing like having the radiology tech try and tell you what x-ray they want versus me trying to tell them what I want. And, I call that the whoop, when I see John Rahm walk up and see what his heart rate is, hit a golf ball. That's my heart rate when the radiology tech tells me this is an outlet view of the pelvis. Get the x-ray versus you have OrthAlign, you go, man, this is easy. And that's what my fellow has said as well. So it's one of those things. I think OrthAlign's been great. Capital cost is low. Certainly as we try and do now, even tourniquetless knees in an ASC, you're not drilling a big hole in the tibia. You're not drilling a big hole in the femur and looking at blood. So you're avoiding, again, hematomas and potential complications. So if you had one case that you were going to choose to use technology in when you transition to the ASC, what do you think that case would be? Is it a DA? Is it a uni, total knee as you transition to using it?
I think that's a great question. I think I don't disagree with Kevin. I think a uni is a great place to start in an ASC in general. But the hard part with that is there are a lot of guys that are just not doing a lot of unis. And so that kind of becomes a little bit of a gray zone. I think if I was looking at this, I think the time saving and the opportunity to do a perfect job is on the total knee application. That's what I would start with. It's what we're most familiar with. It's also the easiest that if you were having some kind of hiccup, right? We all know that with new technology, there's learning curves. It's the easiest one to transition to what you know how to do well. And I think that's an important point in a surgery center, right? As we still are built on efficiency. And it's okay to say, wow, that's not going quite as planned. I'm going to go back to what I know how to do it well. And then you come back and you try again a second time instead of getting yourself so frustrated.
Yeah, and I think the important thing about that is with nowadays with anesthetic techniques, and every patient of ours gets an adductor canal block. So doing the total knee in the past may have been a pain thing. A lot of surgeons were afraid of getting them out of the ASC because of a total knee and pain. The first 24 hours now after a total joint replacement from the knee side is great. It's the next day, and so you got to warn the patients about that. But you get people lifting their legs, straight leg raise right out of the gate, in the recovery room, and they're walking and they feel great when they go home that first day. You warn them about the second day, but I don't think pain has to be something that the surgeon is afraid of anymore with anesthetic techniques and total knee replacement.
Yeah, I agree. I tell them that first day is like test driving a new sports car, right? You love it. You love the smell of the leather. You get home and you immediately have buyer's remorse, right? And then you're like, why did I buy this car? But it's changed our game. The adductor blocks have changed our game.
Yeah.
Excellent. All right. With that, we'll transition over to Mike to tell us what to watch out for as we transition into the ASC.
Great. Thanks so much. And thanks, Steve, for including me tonight. Thanks to OrthAlign for hosting. Always a great group of people to work with, so I appreciate it. All right. So my name is Mike Ast from HSS. And I think really what I'm going to do over the next, I'll try to not make it more than 5 or 10 minutes, is sort of summarize a lot of the things we've talked about. I'm a cynical New Yorker, so I'm going to go straight for the negative and tell you all the bad things that are going to happen. But understanding, of course, I've been doing joints and ASCs for about 7 or 8 years now. And I think if you carefully listen to everything we've heard tonight and apply it sort of methodically and appropriately, you really can make this transition very safe, very fun, and end up with outcomes exactly like we've heard about: better for the surgeon, better for the patient, better for the system, right? That true triple aim of everything we're doing in healthcare today. So when I talk about the pitfalls and the things to avoid, I like to break them into kind of simpler things. So patient selection, and Matt went over this pretty well, but I'm going to touch just very quickly on that. The understanding of appropriate clinical pathways, and we'll talk a little bit about the big 3 pathways that must be in place before you start a program: your pain pathway, your blood management pathway, your fluid management pathway. The third one, that fluid management pathway, is probably the one most overlooked, but most important. And then we'll talk a little bit about what Clint and Kevin both hit on in terms of logistics and what logistics you need to consider before you go from a hospital to an ASC. And then we'll finish up on what everybody's touched on, was kind of the concept of avoiding complications. So patient selection is probably the most important key to clinical success. And Matt did a really great job of kind of outlining the patient he looks for. But really what I like to focus on is who you really have to avoid, right? Ultimately, there are just some people who should never be in an ambulatory surgery center. If you have an extended stay option or something like that, that can be very different. But if you are planning on sending a patient home on the same day of surgery from an independent freestanding facility, you got to avoid a couple people. The untreated OSA patient, right? There's been a lot of data to show that patients with untreated OSA, these are the ones who say they don't have sleep apnea, but their wife says they do, right? These are the ones you want to avoid because their first 24 hours have a very high rate of pulmonary and cardiac complications. They should be monitored overnight on pulse oximetry for the first 24 hours. Preoperative anemia, you really need to avoid simply because you can't transfusion a surgery center. Matt touched on cardiac complications, and I think it's really important. The big one to watch out for is patients with heart failure, especially any level of uncompensated heart failure. Now, most of us don't even know what uncompensated heart failure means, but there are a bunch of cardiologists who do, so I recommend you ask them. And the reason for that is the type of fluid management you talk about for a patient who's going to ambulate and go home within 3 or 4 hours of a joint replacement is not going to be tolerated by somebody whose heart can't handle that level of fluid. So you really want to watch. Morbid obesity is on every single list of contraindications, although I'm not necessarily sure it's real. That's why it officially has a question mark on this page. The New Albany team actually just put out another paper recently showing very good success with morbidly obese patients in an ambulatory surgery center. But keep in mind, they did show in their conclusion that they did have a higher rate of requiring an overnight stay. So you probably do want to be in a place that has at least a 23-hour stay, not one of the freestanding surgery centers in the United States that isn't allowed to have a overnight stay. Probably not great for the very morbidly obese patients. And then social support. This is something that we put out a couple of years ago with our friends at the Rothman Institute, where we looked at the very specific social factors associated with same-day discharge. You want to avoid patients who live home completely isolated from other people. You want to avoid patients who have more than 3 sets of stairs. And the very interesting one that I'm still amazed by, but is super important, is you want to avoid the patient who is the primary caregiver of another human being, whether that's a child, a parent, or a spouse. You can't go home after a joint replacement and immediately start taking care of somebody else. You need to spend a minute taking care of yourself. So those patients probably should spend at least a night in a facility of some kind. They want to be motivated and optimized, and I think Matt did a great job of explaining what that means and why that's so important. From a clinical pathway standpoint, I don't need to spend a lot of time on this. Most people here have probably already thought about this. Pain is the thing that most of us think about first when we're talking about the surgery center. Even Kevin's last remarks really go to the idea that we've got a good handle on pain. You've got to use multimodal analgesia, whatever that means for you. You've got to use appropriate anesthetic techniques, whether that's a regional anesthetic or a general anesthetic. Probably doesn't matter. The Illinois Bone and Joint team has been using general anesthesia for almost a decade, showing lengths of stays of under 2 hours post-op with very little rates of nausea, as long as the anesthesia is done well by the right anesthesiologist. So it's not necessarily you've got to have a spinal or you've got to have general, you just got to have it right. So whatever works out for you, just make sure you build a strong pathway for pain and for anesthesia. Blood management is probably even more important than that. Number one, you're not going to transfuse patients. Number two, when patients are precipitously anemic or hypovolemic after surgery, they can't participate with physical therapy. They can't get up and move. They can't go home. And what you definitely don't want them is to go home and pass out. So you really want to make sure you recognize preoperative anemia. I use it as a hard stop for all of my joint replacements, not just surgery center. If you've got a hemoglobin under 10 or so, you're going to see a hematologist. We're going to think about EPO or something like that before doing a joint replacement at all. But certainly for a surgery center, I like a hemoglobin above 11 because it's been shown with TXA and a hemoglobin above 11, your risk of transfusion is exceedingly small. And when we talk about tranexamic acid or TXA, give it IV, give it to everyone, and then just give it to everyone. If your anesthesiologist says there's a contraindication, tell them to go away. The Mayo Clinic is the data that came out of, I'm sure Clint was probably on a bunch of these studies. The Mayo Clinic data is very, very strong. You can basically give IV TXA to almost everybody. And then we did a study looking at the amount of TXA in the blood after IV versus topical, and they're all therapeutic levels. So if you think that giving topical to somebody is safer, it's not. It's just really safe to give all TXA to anybody. So just give it through the IV, it's easier. And then fluid management is the pathway most people don't talk about, but understand, of course, the number one failure to not be discharged on the day of surgery is nausea, vomiting, and lightheadedness, and inability to participate in physical therapy. As far back as the first real publication by Rich Berger in 2005, the number one reason patients didn't go home on the same day of surgery was nausea, vomiting, and lightheadedness. And this is almost always related to hypovolemia. So you want to look at the American Society for Regional Anesthesia's guidelines on NPO, right? Patients should only be NPO for about 2 hours after surgery. 2 hours before surgery. We tell patients to drink a 20-ounce sports drink the night before surgery and in the morning on the way to the center. This way they're nice and euvolemic when they start. You want to run them relatively euvolemic. You don't want to give them too much fluid because they bleed too much, but you don't want to run them too dry either because you don't want them to pass out when they get up. And as long as you've avoided urinary retention, which we'll talk about later, as Kevin alluded to earlier, once they get up and pee, we actually bolus them another liter of fluid. You really want these patients feeling nice and hydrated, nice and good. It helps them get up and ambulate. It helps them eat because they're not so nauseated. And it helps them get out of the building, which is really what we're all trying for here. So that's the clinical side of all of this, but I think just as importantly is the infrastructure side of the challenges you face with transitioning from a hospital to a surgery center. ASCs, as you heard from a couple of our speakers tonight, really just aren't built for joint replacements. Most ASCs are built for hand surgery, pain injections, and sports medicine cases. And so they don't have sterilizers, they don't have power tools, they don't have beds that somebody can lay on when they have a spinal. And let's say you're not as lucky as Kevin and you're not getting lidocaine spinals, but you're getting mepivacaine or bupivacaine spinals that last for 3 or 4 hours. You can't sit on an ASC stretcher for 4 hours. You get a bed sore, right? So you got to start thinking about things like beds for longer recoveries, helmets, even a mallet heavy enough to whack in an acetabulum is not something that you're going to find at most general ambulatory surgery centers. And so you really need to think about all those things. But the number one thing is sterilization. And in general, it is the earliest limiting factor for the ability to scale a program at a center, right? You just can't do it with what you see here on the left side of the screen, what I call the easy bake oven that most surgery centers mistake for a sterilizer, right? But you can put a GI scope in there. You can put 1 foot tray in there. You can't put 7 trays for your knee replacement. And what you see on the right, that's what a sterilizer looks like at a hospital. And that's the kind that most people think would be necessary for a surgery center. So your job is to understand the sterilization capacity of your center and then make smart choices to deal with that. And whether that's finding a way to limit your trays, finding a way to streamline what you're doing, anything you can do to limit the need for sterilization is really key for the scalability of your program. And then we talked about the size of the ORs, right? So this is the actual operating room from my surgery center. On the left, you see my surgical tech. On the right, you see my PA. And that is a wall-to-wall picture of the 389 square foot room where we do joint replacements. Please don't make fun of the fact that also the lights don't work. So you see that we're using a portable light. The surgery center is a little old and we're building a new one, I promise. But, and no, this is not my HSS facility, to be very clear. This is not an HSS facility. But you can tell that you can't do a lot here. It's even hard to roll a fluoro machine in here when you've got a bed. And so anything you can do to limit fluoro, to limit foot traffic, to limit anything at all, even to limit back tables is really, really important in the supply chain considerations when talking about an ambulatory surgery center. So this is what the back table for my knee replacements look like. You can see we do use OrthAlign technology in our surgery center. I obviously have the conflicts of interest that the rest of the people on this webinar do. But at the same time, when you can do a total knee with 3.5 trays, all of a sudden, this is something you can fit in a surgery center. And just by getting rid of all of the alignment tools from my standard instruments from my knee replacement, this is all it takes to do a total knee in my center. So I have a Mayo stand, 1 back table, and that's it. And you can do that in 380 square feet, I promise. And so things like that are important considerations when you're number one talking about simply transitioning your practice there, but also when evaluating what technology or what types of instrumentation you're going to be looking at. You want to make sure that they're improving your ability to manage the supply chain and manage the utilization of resources like sterilization. And then the last thing, and Kevin actually hit on this, he kind of jumped over this very quickly, but I'm going to sort of call him out on it. He said that he spent about a year doing these cases in a hospital before he did them in a surgery center, right? And everybody's like, oh, I do my case right now. I'm going to go to the surgery center next week. I will tell you that I started planning to do joint replacements in my surgery center in April of 2013, and the first case was done in April of 2014. A full year of developing structured protocol, of getting the right staff in place, of bringing in the right surgical techs, the right nursing team, the people who are motivated and want it to work well, getting the right anesthesia in place, and starting through some of those logistical problems like buying our first set of power tools, getting our heavier mallets, getting our beds, doing test runs where we pretended someone was the patient and we walked them through the center. You know, you are sort of creating something new. And for me, that was really fun and really exciting. And I think a lot of the other faculty here tonight also feel the same way, that building these programs is really fun and really cool and something we didn't necessarily think we'd be able to do when we went into medical school or residency. But at the same time, you need to take it very seriously. If you don't plan it appropriately, you might have the issue where if something is going to go wrong, you didn't catch it or didn't think about it ahead of time, or it goes wrong and you're unprepared. And so you really want to make sure you're prepared for things like backup plans for what happens when you drop the drill on the floor, which happened to us when we didn't have a backup. And I really don't want to tell the rest of the story, right? But you can't have one set of power tools, you need two, right? You can't send everybody home if somebody can't go home that day. So you need to say, I've got a transfer agreement, I've got a local skilled nursing facility that's gonna take them, whatever it is. I will tell you that in 7 years of doing it at my last center, we never utilized that backup plan. We discharged every single patient home. From a discharge standpoint, we transferred one patient to the hospital for a cardiac arrhythmia. But other than that, you still have to have it in place. And I probably wouldn't have brought the first patient there because I would have thought it was irresponsible, not at least knowing what we would do if we need it. And then you've got to avoid the complications. These are highly motivated, highly active patients. But like Clint and a couple of other of our speakers talked about, the other thing is they are also your billboards, right? They're your best advertisement. They're also your worst advertisement when they show up at the ER of the hospital that would have had that case if you didn't do it in your surgery center. Because understand, in many cases, you're not making friends taking joint replacement patients out of a hospital, putting them in a surgery center. I'll tell you a very quick story. When we built our surgery center at my old practice around the Princeton, New Jersey area, the local hospital actually tried to buy the land out from underneath us just for no reason, just so we didn't build the center, right? You're not making friends with these things. So they would love to put a big billboard on the hospital said, look at the pus that showed up from Dr. Duncan's ASC. Is this really where you want to go, right? You got to watch out for that stuff. So you really need to monitor these and avoid complications. Avoid urinary retention by asking about it. It sounds crazy, but just ask. Do you get up 15 times a night to pee? If you do, you might need a catheter, but more importantly, go see a urologist and see if we need to do something ahead of time. I'm of the same, like the rest of the people here. I think we've started things like putting people on sort of preventative medications for that, which has seemed to be pretty successful. But there are some people who, no matter how much BPH medication they're on, they still go into retention. So you got to understand and be aware of it. Nausea, like we talked about before, lightheadedness, like we talked about before, pain, which is actually almost never mentioned as a reason that people can't leave. And that's to Kevin's point that we're just really good at pain and joint replacements in 2020. And then you want to watch out for the patients who go back to the ER for any reason, any readmission at all, you got to watch out for. And usually you accomplish the avoidance of those things by getting like a nurse navigator or someone the patients can call 24/7 or a contact point within your practice that you make sure they come to the office and not the surgery center. So for the first 4 years that we had our practice running in our surgery center, we always left empty clinic spots the next day, the day after, for the rest of the week. And for the first year of our program, we only did joints on Monday, so that we would have Tuesday, Wednesday, Thursday, Friday to see them back in the office, so no one ended up in the emergency room. And little things like that are things you want to take into consideration just to understand, how can I avoid having this patient show up in the ER? But it really all comes down to a strong structured program, empowering all of your staff to get involved and make it better, appropriate patient selection, stick to your protocols once they're built. And then if you've got the ability to identify technology that in your hands improves your outcome, improves your flow, and decreases your complications, that's a home run for you right there. Thank you very much.
Mike, that was great. So, I think we've said a lot of the same things in terms of patient selection's key. One of the things that you hit upon was streamlining the process prior to transitioning. It took you about a year. Did you find that you were able to get those instrument pans down to, 3 pans, give or take, at your main hospital, and then that's how you transitioned over to the ASC? Or did you find that you did that at the ASC?
Yeah, so we started it at the main hospital, sort of starting to see where we could cut and what we could do. The hospital at the same time was also looking for similar opportunities. They just look at it from a cost standpoint. So no one's really upset when you get rid of trays. But we were starting to plan ahead and say, hey, how far down can we go? How far down can we go? And we got it down to about 4, and we really wanted it at 3. And so for the surgery center, we made some specialized trays. But again, this is 2013. If you talk now to most of the implant vendors out there, a lot of them have very streamlined trays, optimized trays, whatever they've nicknamed them. A lot of times, a lot of this work has already been done by pioneers like, you know, some of the people on this call and some of the people that we read and learn, and all of us learn from. I mean, those of us under the age of 40, we've learned from a lot of these pioneers over the last couple of years, and they've done some of this work. So reaching out to your implant vendors, a lot of it's kind of there already.
And do you think, you know, with your not having people necessarily show up in the local ER, is there like a firm cutoff time that you say, you know, we're not going to do your joint if it's after 4 o'clock because, you know, you're going to leave at 8 o'clock tonight? You know, how do you keep your staff happy as well as you try and determine, you know, your timing of the surgeries?
Yeah, this is very much dependent on the structure of your center, right? If you have a 23-hour stay center, if you've got a Dr. Heinrich, you know, your ORs are nicer than my house situation, that's even better. But I think if I'm talking about the true community-based freestanding ASC that doesn't have 23-hour stay, which is how we were, we didn't start your case after 1 o'clock. And so usually our goal was, we did run 2 rooms. So I took both rooms. I did 1, 2, 3, 4, and that was my day. 4 joints, and then the sports or the hand surgeons or whomever came in and finished, or if I did want to do the 2 knee scopes a year that I do, you know, that was it. And I would just do that a couple of times a day. I would do it on Monday and Thursday. You know what I mean? And I'd get my 8 joints in the surgery center, and somebody else would do it on Tuesday and Friday, and our spine team would operate all day Wednesday.
Yeah, we only have one room in our surgery center, and you know, we don't like to start anything. Well, we like to be done by 4 if we're going to do joints. Now we start at 6:30 when we do joints, but so that could be 5 or 6 by 4. You know, it depends if your nurses are comfortable. You know, nowadays healthy patients can go home in about 2 hours. I'm not advocating you start things later in the day, but you know, 6 o'clock should be when most people go home, sometimes 7. I mean, the nice thing in the surgery center is everybody is motivated to get people home, and it's not a turnover staff and things like that. So, you know, you can have them start a little later. You have to be efficient in your surgery. That's not going to be your first case. You know, if you're just transitioning, do them early in the day, give them time to recover, and then see what your throughput is. And then you can schedule your cases, you know, timing differently.
And get an understanding of your staff costs when you do stuff like that. Because if you end up having to pay overtime or something, you want to make sure you don't do that's not going to be in your first 6 months, right? You really want to know what's your nursing timing and when do you want to bring them in? Because like Kevin alluded to earlier, staff is a huge part of your costs.
Yeah. But I like what Kevin said as well. We start our ASC mornings early. So we'll do a cut time of 6:30, and it's, you know, that adds, if you're in 2 rooms, it might add 2 cases. If you're 1 in 1 room, it definitely adds 1 case and still allows you to hit things at a time that's acceptable and get people out feeling safe.
And mainly the urinary retention is going to be in men. I try to schedule men earlier rather than later in the day. I mean, you can get it in women too, but the last thing the nurses, I mean, you'll piss the nurses off if you start a case at 2 and it's a male, and then you're done at, you know, 3, and then he's sitting there waiting to pee 4 hours later. You know, so, you know, urinary retention is the hurdle, and we try to schedule the men at least earlier just so, you know, we don't have that situation.
Yeah, I have a question for the group, and also to Mike. Mike, you said you guys are in the process of building another center right now. Is that correct?
That was at my old center. We built a new one. That's correct. HSS has our centers up and running already.
Because one of the things I'm finding when interacting with surgeons across the country at meetings, things of that nature, is that, you know, there's a lot of people that are now starting this for the first time, building from the ground up. And so a lot of what we've talked about is kind of like if you have that classic, you know, ASC that was built for, you know, like the room you showed, and trust me, I've got one of those, and we work out of that, and it's a different ballgame there, and definitely minimize trays, everything else. The we did our new center, we kind of came at it with a different mindset and to take away some of those barriers. What are your guys' thoughts about if you were building a new one from the ground up today, with the thought that everybody's trying to push for this? So we have 2 ORs. I'll run 2 rooms, and it's a great day for me because it's just me, all me, and so it's sort of my best OR day of the week. And
I think 2 ORs.
What are you guys' thoughts or feedback for other people?
Yeah, I think if you're building a center from ground up and you have the surgeon commitment, 2 ORs I think is key. Because you can be more efficient. The ability to have 23-hour stay, I think, is an interesting one. And if you can plan that, I think it's good because it will expand your case volume a little bit, and you can potentially operate a little longer because they're going to stay overnight. Part of it depends on your also ability to either see the patients the next day or, where the surgery center is. I think you can do a lot of it in a freestanding one that doesn't have 23-hour stay, but if you were going to build it from the ground up, that may be something you want to do because it can expand the patients that can go there.
Well, I think, Kevin, you hit upon a good point is, a lot of the out-of-town patients too, where having the ability for you to be able to see that person who comes in from 200 miles away as opposed to, put them on the road at, 4 o'clock in the afternoon. Having them have the ability to stay overnight, and should there be an issue before they head out of town, is probably one of the bigger things that I've seen has been helpful.
You also need to know your local regulations, right? Because there might be certificates of need or things like that where you could want as many ORs as you want, but you only get one. And so then it's just about planning that one efficiently and appropriately.
Yeah, and that's why we're in Maryland where we're allowed to have one. Now you can have more. I'm in Virginia, and that's a certificate of need state, so we can't, even have it. So, that's also part of the planning process, is understanding your local regulations in terms of, what the ability for you to even have a surgery center is.
I think one other little kind of tidbit to add to that, right, is it goes back to these people being a billboard a little bit. In one of my centers, we do have 2 just kind of little separate standalone 23-hour stays that are very much similar to the rooms that we saw, not nearly quite as nice, but close. But I'll tell you what, that experience for them to be able to go back there, recover back there, my teams, they have a little, 2 or 3 restaurants that are nearby. They bring them in a lunch. It's an experience, and it's boutique. And I think they value that. And that creates a word of mouth that takes away some of the apprehension of the idea of, oh my gosh, I'm going to a surgery center to have my hip or knee done. So there is a little bit of the aesthetics and kind of the appearance that people see that changes perception as well. So in that center, we valued it for sure.
Sure.
And, with this COVID-19 thing where we all face a little bit of a backlog, how many of you guys have seen increased demand for even a shift to do stuff on weekends where maybe there's more support, where somebody from out of town could help the patient get home? That's what I've seen, is more people are asking, hey, can you do my surgery on Saturday morning? Where historically, I don't think so.
Yeah,
don't ask Mike that. Mike's in New York. They got to do that all the time.
Yeah, they do that all the time.
Is that normal for everyone? We just don't.
They start at midnight. All these time things are irrelevant for HSS guys. They start operating on 3rd shift at 1 a.m.
Hey, that's my block time. Don't make fun of my block time.
Yeah, no question that COVID has brought the outpatient conversation to the forefront for most patients that you're seeing nowadays. Whether it be on a Saturday, that's up to you. But most of them ask, hey, can I go home? Do I have to stay? And then you have to be, as a surgeon, understanding, well, you've got certain reasons why you couldn't, but there's a lot of people who in the past you might not have thought, could go home, that are now wanting to do that.
And Clint, I think we all really enjoy technology. I don't think any one of us on this panel would say that we would love to do a intramedullary rod in the femur ever again. So, one of the biggest things that I faced was trying to convince our folks to allow me to use, technology, predominantly OrthAlign on both unis, total hips and total knees. For me, I was able to go through and show decreased operative time, decreased pans, makes the sterilization process easier. What do you think some of the keys were for that transition to make it feasible for you?
So I think you hit on two of them, right? I mean, that's going to be what the overlying answer of your quote unquote board or the people that are involved in making the decisions. Fortunately, I think to some of the things that guys have already spoken on, as joint surgeons now, we've become an asset to surgery centers. And so if you have the ability to bring more cases and can allow for that, they all stand to benefit. So I was actually surprised. I didn't have much of a financial pushback on inventory and on being able to bring that in. And then I went to OrthAlign and we were able to navigate even a little bit more premium pricing based on volume. And with that in mind, that kind of assured them that we're getting we're getting kind of the best price we can. But when we bought that many, it also was a commitment on my end that we're doing them there and we're going to continue to do them. And so when they saw that commitment both ways, I didn't have any pushback for many of the board members on the cost. I don't know if anybody else has had anything different, but I think as joint guys, we have a little bit of leverage now because we bring something important to the equation.
It's interesting. You get this conversation in the hospitals when you say, I want to spend money, the answer is no. And then you got to figure it out. But the surgery center, you sit on the board, right? You get to be the one who determines the definition of value to your center. And I'll tell you, if I'm the hand surgeon and Clint says he's going to do cases at my surgery center, I'll be like, great, what do you need? It's as simple as that, because we understand that a surgeon with an ownership is going to look at that value differently and be responsible about it. So the conversation I find is actually easier in the surgery center.
Yeah, and as the surgeons understand, the joint replacement surgeon to the surgery center is now the most, desirable and valuable surgeon to be there. So you can't open the checkbook, but you can spend a little money to bring your cases there.
Yeah, another big point I found is that without the capital side of this, it's a very different concept because at my original ASC, to answer your approach, used to use in the HANA table, and so when I talked to the guys about, hey, let's buy a HANA table, well, that's a pretty big capital outlay, and you have to factor in how many cases I'd have to do in order to actually pay it off. And so they wanted me to kind of prove it out. So I actually had to do cases without it first, get enough of them under my belt so they could actually see the financials to say, okay, we're going to generate this much per case. And then they could put it together and say, all right, if you commit to this much volume, we'll go ahead and get it. With navigation, with OrthAlign, I never had that. They were like, oh, there's no capital? Okay, you're good to go. Because they could very easily look at that per case thing and say, all right, we're not worried about, you have to do so many to make up for the cost of this. It's, since it's an isolated per case, expense, that's, a fraction, and actually, usually about the same or less than what you'd pay, go ahead and pay for any other type of a robotic system per case. It was a no-brainer. So.
Yeah. Good.
I guess last question to pose out there, and probably for Matt and Kevin and Mike and Clint, if we all had that crystal ball of, seeing what's going to happen in the next 5 years with, CMS getting involved in reimbursement and everything, do you think the ASC will become more of the way of the future and we'll start seeing less of the hospital-based total joint, potentially even for some of the sicker patients if we can try and find a way to optimize them?
Yeah, I'll jump on this. With CMS allowing for outpatient, my goal, I've actually kind of set it for next year, is to try to cut down to only operating in a hospital maybe 1 or 2 times a month. And then everything else is going to be outpatient. And currently at our new facility, about 20 to 25% of our, patients are already ASA 3s. And so I think with appropriate optimization, we've proven you can do it safely. And so, that's where I see myself headed.
I think definitely it is going to continue to increase and be the wave of the future. There's going to be centers that still are going to have to do things at the hospital for more complex cases. But I think the patient selection and patient optimization can be expanded. Mike touched on the morbidly obese. If you've got anesthesiologists who are willing to deal with those patients or, safely, they do just fine at a surgery center. It's going to be the heart failure patients that are the ones you're going to have to worry about. And, optimizing most people, there's going to be a huge, transition to outpatient surgery. So, as the surgeons out there listening, you got to start dipping your, foot in the water and, start getting out there and doing them. Mm-hmm.
Yeah, I would agree. I mean, we've got Intermountain Healthcare, which kind of runs things here, and it's interesting. They've built a bunch of smaller scale type hospitals, but in the end, they're still going to end up skeletonizing them a little bit. And so there's this, even within this large organization, you see two different thought processes. You have the bean counters that are on the hospital side that don't want to see those cases being moved, and yet then we have conflicting interest where we have all the physician partners and kind of this ambulatory side that is saying, no, we want all of these cases out of the hospital. So I think even the hospitals themselves internally are struggling with this. But I definitely think the number we're going to see, in that 35 to 45 to 50% of folks without much trouble being able to do it. And then I think the question is, where does that next 10, 15, 20% of patients lie? Those are the gray zones. And then I think we clearly have 25% of people or 30% of people that are always going to need a higher level of care and the ability to stay longer.
I think if you just look at some of the progressive health systems in the country, they're showing you what they think is going on. So look at something like Wake Forest Baptist Health or down in Emory, right? What are they all doing? They're all building orthopedic specialty hospitals and ASCs, right? I think the future of everything we do is not in the old-fashioned brick and mortar general hospital. I think there's going to be an increase in surgery centers like we heard, but I also think specialty hospitals are going to be the answer for the patient who can't go to some type of a day center. And whether that's a specialty hospital within a big health system, or just, let's say a health system happens to own 5 hospitals and they just turn one of them into the orthopedic hospital, or a physician-owned orthopedic specialty hospital, or a place like HSS, it doesn't really matter how you sort of make it look. I think that's the future of hospital-based orthopedic surgery, and that everything else is going to be outpatient.
I want to thank everybody for tuning in tonight. Kevin, Matt, Clint, and Mike, thanks again for going over, the key portions: patient selection, economics, technology, and the watchouts. And be fun to see what happens in the next 5 years. Thanks again, guys.
Great. Thanks, everybody.
Thanks so much.
Thanks. Appreciate it, guys.
Guys, have a good night.